Announce after the first talk, sir, in detail.
Okay, ma. All the best. Okay.
So, once again, welcome all. I'm Dr. Prashant Goda, Secretary NNF Karnataka Chapter. So, we would like to give a warm welcome for all the participants who have been consistently participating from last 2 months. And your passion towards learning is greatly appreciated. Thank you very much for sparing time and for learning. So, today we have two wonderful speakers, Dr. Siddharth from Coimbatore and Dr. Giridhar from Chennai. And these two have been national speaker for many conferences as well. Thank you very much for accepting our request and being part of this webinar series. Over to you, Dr. Siddharth. Dr. Siddharth is a neonatologist, chief neonatologist working at Sri Ramakrishna Hospital, Coimbatore. We give you a warm welcome on behalf of NNF Karnataka office and all the members of NNF. So I request Dr. Kishore, sir.
Hello.
Yes, sir. Yes, sir. Yeah, to say a few words, so we'll start the session.
Oh, thank you, Prashant, and thank you, the whole NNFK team. Unconjugated jaundice or conjugated jaundice is a problem which all of us face in everyday life, and there's not a single neonatologist who won't see this problem in day-to-day life. And we are very, very fortunate to have both Dr. Siddharth and SETHURAM educating us today about nitty-gritties. And I'm sure we will find a few points to take home, even if we are all practicing pediatricians and neonatologists from this lecture. Thank you very much.
Yeah. Over to you, Dr. Siddharth. Please start the session.
Thank you, sir. Thank you, Dr. Prashant and Dr. Kishore Kumar, Dr. Dinkar for this opportunity. So I think, as Dr. Kishore Kumar said, this is a most common neonatal topic, and all of us are very well versed in this. But let this be like a refresher course for all of us. So our objectives for today will be current scenario, what are the causes, pathophysiology of jaundice and the bilirubin encephalopathy, approach to how to handle jaundice, clinical jaundice, and then we'll go into treatment and any other new research that we see. As we are all aware, jaundice is not just skin deep. We all worry about it because it affects the brain, and we still see kernicterus in all our babies, in many of our babies. So it is still a problem that we constantly face in this day and age of tertiary care and ICUs. The incidence of jaundice is about 60 to 80%, as we all know, but only about 1 in 10 have clinically significant jaundice. There's a severe jaundice, which is meaning more than 20, with some mild bilirubin-induced neurological dysfunction, happens about 1 to 66 in 1,000 live births. So the lower end is in the Western population, and the higher end is in the developing world. So jaundice accounts for a very big number. And as far as kernicterus for 1 lakh live births, it's much higher in the developing countries, Africa and Asia. So this is a global burden of disease. How much does jaundice contribute to disease in newborns? So it's almost like 1,300 deaths per 1 lakh live births, which is a huge number. And it is the 7th amongst all the neonatal mortality in the first week of life. So that's even in this time, so jaundice still accounts for a lot of this mortality as well as morbidity. But the one good thing about this is it is preventable. All of this is preventable. So if we do it properly, we shouldn't be seeing this kind of mortality and morbidity. We'll quickly go through bilirubin metabolism and the causes of jaundice, because all of us are aware of this. So the bilirubin is produced from senescent RBCs, the old or deformed RBCs, and the heme that comes from it is changed to biliverdin by heme oxygenase enzyme. In the process, carbon monoxide is released. The practical point here is carbon monoxide monitoring can be done at bedside. I'll tell you a real-time indicator of hemolysis. The biliverdin that comes from heme is again reduced to unconjugated bilirubin by bilirubin reductase, biliverdin reductase. So the unconjugated bilirubin needs to be attached to albumin because it is not hydrophilic. So only by binding with albumin, it is taken to the liver, where it is uptaken, conjugated with uridipic glycosyl transferase enzyme, and then the conjugated bilirubin becomes water soluble, and is excreted in the bile. In the intestines, the bacterial proteases act on it, and the urobilinogen is formed, which is again excreted in the feces, as well as some M1 is absorbed in the blood and excreted in the urine. Again, if we don't feed the baby very well, the conjugated bilirubin here is broken down back into unconjugated bilirubin and gets reabsorbed. So this is the enterohepatic circulation of bilirubin. And breastfeeding jaundice, where there is insufficient lactation, causes increased levels with this kind, with the increased enterohepatic circulation. So bilirubin is a potent antioxidant, even in nanomolar concentrations, and it is also protective against infection. So this is the reason why newborns actually have jaundice, have a little bit of bilirubin to protect against the stress of delivery as well as infections. But at higher concentrations, it causes increased reactive oxygen species and oxidative damage. Just a word about this heme oxygenase enzyme. There are some genetic polymorphisms in this. If it is expressed high, it can cause high bilirubin, where a lower expression causes oxidative injury or IUGRs, abortions, etc. Some physiological jaundice can have genetic polymorphisms of HO1 with higher expression. Again, a practical point here, metalloporphyrins were tried to reduce the jaundice by acting at this step, but it never came from the research side to the clinical side. The most common cause for us is physiological jaundice with increased RBC destruction, because newborns have more amount of RBCs, preterms more so. IDM also has more polycythemia. But the main cause is decreased liver conjugation. If you see this graph, the UGT activity here, the term babies are represented by the dark circles and the preterms are the triangles. Both of them have lower levels at birth, and they slowly increase over the period of time. So this is the main reason why we have newborn jaundice in the first 1 week of life, physiological jaundice. And as by day 14, they reach adult levels. There's also a decreased uptake in the liver. The ligandins are less expressed, especially the Y protein. And as we discussed already, there can be increased enterohepatic circulation if breastfeeding is not going well. Physiological jaundice usually peaks by 4th day. We know that it declines after a week. Preterms can have it slightly later, the peak. Also the physiological jaundice lasts for a longer time. The initial period, the first week of life, is usually because of conjugation, and the later on, day 5 to day 10 is usually because of reduced uptake. So coming to pathological jaundice, it's within 24 hours or that persists beyond 3 weeks, 2 to 3 weeks. The rate of rise is higher, like 5 mg per day, and the presence of conjugated fraction, and if there is severe jaundice, that's more than 20, all these are called pathological jaundice. And the main thing that we need to remember for pathological jaundice is increased production of heme. So hemolysis. If you're seeing jaundice on day 1, it's invariably more or less hemolysis. So hemolysis, our main cause is Rh and ABO. The others are being hereditary spherocytosis, the membrane defects, the enzyme defects, G6PD and PKD. Sepsis contributes a lot in low-income countries. Any bleeding, traumatic injury, cephalhepatoma, subcalial hematoma, bruising in preterms, all this can cause increased jaundice. The other cause is decreased binding of unconjugated bilirubin. The albumin can get saturated. Albumin levels can be low, and this can happen in premature IUGR. It can be affected by drugs like sulfa and ceftriaxone. Acidosis and hypoglycemia, where the albumin binding site is competitively inhibited, so bilirubin is not bound and becomes free. In such a case, the free bilirubin can diffuse into the tissues and cause brain damage. So the measurement of free bilirubin also can happen, is available, but not really widespread. So only in Japan they do it, but it can give a fairly better idea of how much at risk of neurotoxicity you are. So again, some inborn errors of conjugation where the enzyme is defective or decreased in quantity, like regular Naja and Gilbert syndrome. The increased enterohepatic circulation with if there is block in the intestine, like surgical blocks, you have either atresia, intussusceptions, pyloric stenosis, ileus, all these can cause jaundice via increased enterohepatic circulation. The rare ones are metabolic and thyroid, but these have conjugated bilirubin function along with them. Just a few words about isoimmunization because we see this a lot. The RH disease, the awareness of the risk is much higher now. We always diagnose it antenatally. And because of the availability of the anti-D immunoglobulin, the death in this is reduced by 100%. So also the severe jaundice and exchange levels have reduced considerably. But the DAT on cord blood and early bilirubin screening also have decreased exchanges in this population. But what we see majorly is the ABO isoimmunization right now. So 15% of pregnancies have this setup. A few, like 30% of them have positive Coombs test. Jaundice usually in this typically rises rapidly on day 1, which continues at a slower pace. Awareness of ABO isoimmunization is lower with early discharges and lack of follow-up, and that's the major cause of severe jaundice in this setup. So there are several studies, population studies, which show that 50% of all connectors and hazardous jaundice is because of ABO right now. So we'll come to this again later, but it is better that we can do a blood grouping, typing, and screening for the mothers. And as soon as they have a first visit, and indirect Coombs test also on all pregnant women. A repeat scan can be done at 28 weeks to identify if anybody has new onset immunization. And if babies are born to somebody who is already known to have antibodies, better we do everything in cord blood, like blood grouping, typing, DAT on the cord blood. As well as all babies with RH setup, it is recommended to do it. ABO setup though, it is not recommended, but it is better to have because most of these cases right now are turning up with ABO incompatibility. Most of us are doing with the delayed cord clamping. So there's a concern that people might have that because you're transferring more RBC, whether you get more jaundice. Two studies, one actually came just now in March. It's a nice study where they did 1981, that's a large number of pairs with early and late cord clamping. They saw that up to 90 seconds, you had the DCC group had higher hemoglobin, no increase in phototherapy, even though they had higher hemoglobin and hematocrit. Only if you go beyond 90 seconds, they had a higher phototherapy. There was one more study also, which also showed that in term babies, it's okay even if DCC goes beyond 3 minutes. There was no change, no difference in bilirubin and phototherapy levels. Coming to bilirubin encephalopathy and bilirubin-induced neurological risk, or it's also called the BIND. And have acute effects of bilirubin on the brain, which can lead to what clinical syndrome is called the bilirubin encephalopathy, acute bilirubin encephalopathy. So stage 1, the baby is lethargic, has poor suck, variable tone. Stage 2, tone is increased. Baby in the picture shows opisthotonous with extended back, arched back, and high-pitched cry. Stage 3, retrocolis, inconsolable cry or deep stupor, seizures and death. So stage 1, stage 2 are potentially reversible with early therapy, whereas stage 3 is irreversible. Connectors. Mollison actually described this link between bilirubin to connectors, and that happened in 1954. So the current incidence is about 1 in 40,000 in the West. Again, can be higher in our countries. The risk factors being jaundice severe jaundice, like more than 20, but it's about 30 to 35 is definitely related to increased risk of connectors. And if the rate of the raise is 0.5 mg per deciliter per hour, you can have higher incidence of connectors even at lower bilirubin levels, because when the fast increase in bilirubin saturates the albumin binding sites, and you have more free bilirubin. And so you get into quicker brain deposition. Clinical signs of acute bilirubin encephalopathy, sepsis. If you have clinical signs, definite a risk for connectors. And then again, if you have sepsis, asphyxia, acidosis, low albumin, these all can penetrate the blood-brain barrier, the permeability increases, and therefore you get connectors. Similarly, extreme preterms, the connectors levels get very low. The bilirubin levels at which connectors happens is quite low. So we need to be aware that these are not the same as term or late preterm babies, and phototherapy can be started early on. Clinical syndrome, mainly the motor involvement is dystonic CP, hearing loss and oculomotor impairments, and enamel dysplasia. The pathophysiology is the bilirubin enters into the CNS, and then it causes membrane injury, where it disables the ATPase pumps, and that causes increased glutamate, increased calcium in the cell, and free radical injury. And mitochondrial damage also happens, that also leads into the same cell death problem. So bilirubin deposits preferentially into globus pallidus, subthalamic nuclei, cerebellum, the auditory pathways. So that's why we see mainly dystonic CP with auditory issues with an intact cognition. So the poor thing is these people are in a locked in state. They can't really move or talk, but their brain functions okay. So that's a very sad situation to be in, and this is potentially reversible all the time. So this is the MRI picture. You can see the cursor is the globus pallidus hyperintensity, and this is the yellowish discoloration on the autopsy specimen. Important to remember that connectors can develop even with a normal MRI after acute bilirubin encephalopathy. This is a nice slide detailing what happens in preterm infants. So preterm infants are at increased susceptibility for connectors, and that's because all the mechanisms are amplified. So total bilirubin increases because you have shorter RBC span, conjugation is impaired. Free bilirubin is increased because of low albumin, and drugs are used. They are likely to have more acidosis, hypercarbia. Therefore, the bilirubin entry into CNS is increased. Because it's a growing brain, the susceptibility of host cell to damage is much more than a term patient. Let's come to approach to jaundice. For all babies, and this approach is derived from multiple guidelines like AAP, NICE, Canadian Pediatric Society, Indian guidelines. So I just made kind of a gist for all of us. So for all babies, we need to have ongoing periodic inspection for jaundice for the first 72 hours, at least twice daily. The picture is showing the Kramer's chart. And though we are not, the clinical jaundice is not really reliable, but that's the first, that's the best thing to do initially. The NICE guideline says unless you have clinical jaundice, you don't need to do a TCP or TSP. AAP disagrees completely and says clinical jaundice is not really that reliable. We have to do a pre-discharge screen. The second step we should do is identify risk factors. The risk factors is all those causes that we have already talked. The rest of them being late prematurity, mothers who want to breastfeed, sibling with the previous sibling with needed phototherapy, and pre-discharge screen being in the high risk zone. These are the major risk factors in addition to hemolytic causes. Primary prevention is to provide breastfeeding support, make sure that somebody is there to teach mother how lactation and latch, educate parents about jaundice, and if they go home, how to check for jaundice. And again, for DAT, for the isoimmune hemolysis setups, like if mother is Rh negative or O, or has a positive blood group antibody already, we should get blood grouping and typing on cord blood. We should get a direct Coombs test on cord blood. And if there is identified to have incompatibility already, like the mother has ICT positive or antibodies are positive, we should arrange for blood for exchange before the baby is born. And we should do bilirubin in the cord blood or early bilirubin for the baby. So these cord blood bilirubins need to be followed up. People do forget about to follow them. And if it is less than 2, it's okay that you're safe zone. If it's more than 4 to 5, you must keep a watch for developing severe jaundice. So how do we test for them? If a baby is jaundiced within day 1, like within 24 hours, better to do serum bilirubin because we have to look at direct fraction also. If the baby is jaundiced excessively for age beyond 24 hours, you can do either TCB or TSP. TCB is transcutaneous. And if TCP is more than 12 or 15, it becomes unreliable. It doesn't show a value sometimes. So we need to recheck that with doing a serum bilirubin. the first sample of bilirubin always get a conjugated fraction. So just take 2 slides on TCB. The picture there is showing the Dagger jaundice meter. It's the most used worldwide. Simple, non-invasive, reasonably reliable measure of bilirubin. What it does, it sends light into the skin. Depending on how much bilirubin is there, the reflected light is measured for diffuse spectra. So new generation devices are built now, have built-in algorithms which account for skin pigmentation, skin thickness, and all. So they can still be used in dark babies who have polycythemic, etc. These were the concerns with the earlier devices. So other Philips has BiliCheck and Natus has BiliCare. These are all the other devices that are available. So because they reduce pokes to babies, reduce pain, and reduce infection. So this is a good measure, non-invasive measure that we all can have. So guidelines are, we can use TCB in greater or equal to 35 weeks as a screening tool, but not during or after photo, and not to use in preterm infants less than 35 weeks. The sites are usually the forehead, sternum, or the earlobe, depending on the manufacturer and the machine. That we should remember to avoid hairy areas, pigmented areas, areas which have birthmarks or blotchy. So that is the thing with TCB. We have TCB nomograms also with multiple sources. This one on your screen is the Indian one, published in May 2017 from Gujarat. Recent research, there's a systematic review of 22 studies on TCB. It showed that even in preterm babies, the correlation was very good, 0.83. And they did this research with BiliCheck and JM103. And again, in one more study, which included both term and preterms, the TCB was 0.6 and 2.4 less than TSB before and during photo. So the correlation was still there, except that the TCB was measuring slightly lower than the serum bilirubin. So this was calculated that if TCB is 7.3 below phototherapy threshold for that baby, you don't need to do TSB, and safely you can stop phototherapy. So I think these things will be incorporated into guidelines soon, and probably they'll tell us that TCB is okay. But right now the guideline is not to do TCB during or after photo. So how do we start treatment? If your bilirubin level crosses the nomogram threshold value, you have to start treatment. The nomograms are again from multiple sources. I'll just show you them. And we have to identify the neurotoxic risk factors before interpreting nomogram. The neurotoxic risk factors are those which increase the blood-brain barrier permeability, so that is, and cause hemolysis. So one is isoimmune hemolysis, G6PD, sepsis, asphyxia, acidosis. All this you'll find in the chart itself of AAP. When do you give intensive phototherapy? If TSB is rising rapidly or within 3 mg per deciliter of the exchange level, you do intensive. And monitoring during phototherapy, if the value is more than 25, you repeat in 2 to 3 hours. If it's more than 20, within 3 to 4 hours. If it is less than 20, you can do it in 6 hours. And if it's stable and falling after that, you can repeat in every 12 hours till it becomes less than 2 to 3 of the threshold value for photo. Then you can stop the phototherapy. These are the AP charts for phototherapy, all of you know. And they are both for phototherapy and exchange transfusion. The top line is for the term babies more than 38 weeks without risk factors. The middle with risk factors with 38 weeks, or the 35 to 37 without risk factors. The bottom line is for the 35-37 with risk factors. And this is the preterm charts. And these are available on Neo Reviews, just released in May 2020. This is again from Vancouver, Canada. They have from 22 to 25 weeks, every 3 weeks gestation, they have charts. The good thing about this chart is the green line is discontinue phototherapy. The blue start, the yellow is alert level for exchange, and the red is an exchange level. So these nicely tell you when to stop and start. So this is the advantage with them. We can see that the exchange levels are very low. So for 24 weekers, the exchange level comes to around 11.5. 200 millimoles is 11.5, around milligrams per deciliter. each milligram per deciliter is 17 millimoles. And this is the phototherapy chart for preterms we use in our NICU, and this is derived from 2003 archives article data on that. So when do we consider exchange transfusion? See, if bilirubin is more than 25 or more than 20 in sick babies, or bilirubin is in exchange transfusion threshold in the hour-specific nomogram, or it is rising rapidly even under phototherapy, and in any baby with acute bilirubin encephalopathy, even if the bilirubin level is not that high. So this we need to remember. And we should not delay exchange transfusion if it is indicated. And a repeat bilirubin, just, because if you start arranging for exchange, it takes minimum about four hours to get the blood back into the unit. Before that time, you can repeat a TSB again, just to make sure that it is still in exchange level. What testing we do? Jaundice on day 1, we can do, and excessive, if the bilirubin is excessive for age or requiring photo, and it's rising rapidly, we can do the same that we all talked about till now. In addition, we can consider G6PD. If it is approaching exchange level, definitely do your blood work, because for the next 3 months, you won't be able to do anything. So if you can do G6PD, any other hemolytic workup you're suspecting, like flow cytometries, osmotic fragility, HPA electrophoresis, metabolic screen for TMS, and genetics, these can be considered before doing exchange if you don't know the cause. If direct bilirubin is elevated, you should do a urine screen and septic screen. Jaundice after 3 weeks, or the baby is sick, always obtain conjugated bilirubin level, again do a septic screen, thyroid metabolic screen, and cholestatic workup, as Dr. Giridhar is going to tell us next. So there is a study which said that this is a guideline from AP saying that all phototherapy babies should have count, smear, and the blood group typing DAT done. They saw that they were all normal for 88%. Only those who got positive results were those babies who got jaundice before 48 hours. That's something maybe we have to think of, because after 48 hours, it's mostly physiologic jaundice. So we probably can limit some amount of investigation there. So just a flow chart of how to approach jaundice in the first week. If the baby is well, and then you have early jaundice or rapidly increasing, then you analyze for hemolysis. Hemolysis is yes, you have to see whether it's DAT positive or negative. DAT negative, but hemolysis is present, rule out other hemolytic causes, RBC, membrane, enzyme defects, and all that. If hemolysis is present, but it is DAT positive, it is isoimmune hemolysis. DAT hemolysis is not present, but the bilirubin is rising and it is early, early jaundice, it is not early jaundice, and it's not rapidly raising, then it's most likely physiological jaundice or breastfeeding jaundice, polycythemia, and bleeds. Jaundice after 7 days is fairly simple. You have to take a conjugated bilirubin, and if it is present, it is usually sepsis, torch, infections, metabolic disorders, and cholestasis. If it is not conjugated bilirubin, and there is no ongoing hemolysis, the most common cause is breast milk jaundice. Again, some bilirubin conjugation disorders can present, and hypothyroidism. Ongoing hemolysis is present. Again, you have to evaluate for G6PD and other causes of hemolysis. Just one thing to remember here is, after hemolysis, G6PD levels can be not truly representative. Similarly, hereditary spherocytosis cannot be diagnosed after a big chunk of hemolysis. So we might have to repeat these tests again. So this is a pre-discharge screen. AP recommends pre-discharge screening for all newborns in the first admission. So the chart that you see on the screen is a Bhutanese chart, as all of you are aware. Whenever the baby is going home, if it's going home before 72 hours of life, take a bilirubin, plot it on this chart. If it's falling in the low risk zone, you can probably wait for 3 days for the baby to be reviewed. Between low risk and high risk zone, if the baby has any other risk factors, you will review within a day. If there's no risk factor, you can wait for 48 hours. If somebody is falling in the high risk zone, not in the high intermediate, the high risk zone, we should evaluate that the baby is needing phototherapy or not at that point itself, because this is actually the treatment level. There is a study from Sweden which said the importance of adherence to these guidelines. They said that they had some 13 kernicterus cases in a period of 8 years, and most of them, 11 out of 13, were preventable. 6 were delay in ET, 6 did not have a pre-discharge screen. So this is just showing how important all this is. Coming to the final segment of the talk, we'll talk about phototherapy, exchange, and IVIG, and then finish. So phototherapy, that was the first picture was of the first phototherapy machine. That was in 1956 in England. So right now, after the AAP guidelines in 2004, the phototherapy has increased to about 8% of all newborns get phototherapy. In NICU, about quarter of them. In extreme preterms, almost everybody, 80 to 88% get. But this is also accompanied by a huge reduction in bilirubin reaching exchange transfusion levels. What is the mechanism of action? The light reacts with bilirubin and forms isomers. These isomers, the confusionate isomers, rapidly are formed. They are hydrophilic and can be excreted in bile, but they take long time for excretion. There is a structural isomer called the lumirubin. Takes time to form, but is rapidly excreted. So both these are the major mechanisms by which bilirubin is converted into water-soluble forms. What are the factors affecting phototherapy? The spectrum of light emitted. So this is best effective at the blue light. So that's 450 to 470 nanometers. Because the skin, that's the maximum absorption by bilirubin, and the skin penetration is maximum at 459. So that's why we choose this bandwidth. People have tried different levels like turquoise lights, green lights, but they're not really better than the blue ones. Irradiation, you have to measure with a radiometer. The standard is about 8 to 10. Intensive means more than 30 microwatts per centimeter square per nanometer. How do we increase this, irradiance? That is, you can do increasing surface area exposed. So that's called the spectral power. The spectral power is equal to surface area multiplied by the irradiance. So if you want to make it more intensive, you expose a lot of skin and also increase the irradiance. So cause of jaundice is less effective in hemolysis because there's an ongoing cause. And if the level at the start of phototherapy is higher, you'll see a faster reduction in jaundice levels. Other factors are cycling. Dialysis is just one, but this can be probably used in extreme preterms to save them from post-oxidation injury. Turning of infants under phototherapy is not required. And higher hemoglobin can sometimes competitively absorb light and decrease the effect of phototherapy. Fluorescent lamps, what devices we use are 5 lamps that we use in phototherapy. They are frequently used with white or daylights to reduce the glare and nausea to caregivers. But the problem with this is that we have to replace them every 1,000 to 2,000 hours. Halogen lamps are those sometimes fitted with the warmers and incubators, cause only a small circle of irradiance. They are caregiver friendly, but they produce a lot of heat, but they are not very effective because they only illuminate a small area. LED lamps are the state of art. They are most effective. They last more than 20,000 hours. They don't cause heat. Very less energy is used. They are caregiver friendly. Billy blankets, as all we know, can be used directly in contact with skin, but they're not very effective. So you can use them to help increasing the spectral power by putting them under the babies. But in extreme preterms, it can sometimes be just enough. So nursing care that we need to do is we have to ensure that there is adequate irradiance. Somebody needs to monitor the radiation, the radiance level. If we want intensive, it should be intensive. And for that to happen, we can keep the LED lights quite close to the baby, 10 to 20 centimeters. expose the baby's skin quite well. So if it's too tight, there should be frequent change. We should watch for infections. Sometimes corneal abrasion injuries can happen. Temperatures need to be monitored. Even sometimes with even this high intensity, LEDs also can cause heat generation. So in all this, we should be remembering that mother and baby are, the mother is stressed out, and we should promote mother-baby interaction as well. Just adverse effects, we all know that loose stools can happen, skin rashes, water loss and temperature instability, bronze baby only with cholestasis. And the other important thing is circadian rhythm is disturbed. It decreases the melatonin, which contributes to development of sometimes reversible hypocalcemia. Some interesting adverse effects. This is again a population study from Sweden. It shows that there is some increased incidence of allergic disease and asthma because the phototherapy blocks the shift in the immune system. It's hypothesized that bilirubin helps to promote the immune switch, and by doing phototherapy, we are stopping. So they did find some late onset asthma and allergic rhinitis increased incidence. There's also a 2016 study which shows there is mild increase in epilepsy in boys only and not in girls. And no cause was actually hypothesized by them. There was a study in 2008, it's a 5% increase in mortality in 500 to 750 gram babies with aggressive phototherapy. So here we really need to take a balance between whether connectress risk is there or photooxidation injury risk is more in preterm infants. So the graph, you see the upper graph, upper line is the bilirubin phototherapy group, where there is so much photooxidation injury compared to the control group. So this is done in newborns, not in animal study. Coming to IVIG, it's used in immune hemolysis. And when bilirubin approaches exchange transfusion levels, we can do IVIG, because the mechanism is there's a non-specific blockade of the Fc receptor. Therefore, it prevents the cytotoxic hemolysis. The dose is 0.5 to 1 gram. We can repeat the dose again up to 2 doses. But the thing is, all the evidence that is on IVIG comes from small studies, and they're all biased. So we really don't know how effective it is, though it is routinely recommended and routinely used. Even in our unit, we use IVIG. But Cochrane in 2018 has said, no, there is no evidence for recommendation, and decision should be based after detailed assessment of benefits and risks. Exchange, rarely used nowadays. All our efforts are going towards preventing of exchange transfusion. We should do double volume, and the blood that you use for exchange should be cross-matched with mother and compatible with baby also. The mortality risk is quite significant, about 3 per 1,000. And you have a lot of electrolyte, metabolic disturbances, risk of sepsis, neck. And there are also poor neurodevelopmental outcomes after exchange transfusion. We don't know whether that's because of the high bilirubin or the procedure itself. Other drugs have been tried, like phenobarbital. This phenobarbital induces liver enzymes and increases uptake. It's helpful in some disorders, like regular nausea type 2, in some cases of prolonged jaundice. But the recommendations right now are we should not be using phenobarbital for indirect jaundice. Metalloporphyrin, similarly, we have already talked about it. They are mostly in research settings. It has not come to bedside. Right now, the studies are focusing on doing massages, giving probiotics to babies, giving laxatives. All these are showing some benefit in small studies with a lot of bias. Right now, there is no recommendation for any of these. Just one penultimate slide. It's on crash cart approach. It's called emergent therapy to prevent connectors. So if you see a baby in your OPD or in the clinic and has severe jaundice or signs of bilirubin encephalopathy, our whole effort should be to make sure that the baby's treatment starts as early as possible. And wherever delays are there, we should be making sure that they are prevented beforehand itself. So we have to make sure the baby goes directly to NICU and not waste time elsewhere within 30 minutes of baby coming to you. Phototherapy could be started even on transport if that's available. In the NICU, again, workup should be immediate, but don't wait for the results to come. start intensive phototherapy without waiting for results. And then start IV fluids, make sure sepsis is treated, asphyxia is treated, acidosis is treated if it's there. Consider IVIT, delay in exchange transition. So this is a crash cart approach which was suggested by a number of studies. They have seen that even with advanced encephalopathy, if you do the emergent therapy for the bilirubin, they see that the kernicterus is prevented in most cases. Future trends. We have genetic testing for polymorphisms, like we were talking about, UGT enzyme and hemoxygenase and the other inborn errors of bilirubin. We'll probably get a small chip to check for these genetic tests, and then they'll tell us the direction in some next few. That's for the advanced countries. On the other side, if you see the filtered sunlight canopies for the low poor countries, where the picture there shows a study from Nigeria, where the canopy absorbs all the UV radiation and only sends in 400 to 520 nanometer light inside. It was found to be effective in a simulated setup. But still, only a few studies have been done. Again, it's not been widely practiced. We should not be exposing our newborns to sunlight just because of these studies, because still they get into burns and UV radiation. Still recommendations have not changed, but this is something that they're doing in research. Again, stem cells, as always, might be coming in for a few of disorders which cause neonatal jaundice. So the take home is still very common cause of morbidity and mortality. It's largely preventable with proper pre-discharge screening and identifying risk factors. Treatment should be appropriate and timely. LED phototherapy, it's good to invest in it, and ensuring intensive phototherapy will go a long way in preventing. And we should have a written policy in the unit on jaundice. Everybody should be educated about it. There should be ensuring compliance for it, and parent education will also help us prevent side effects of long jaundice. These are the links for nomograms that I have put up. The top one is the NICE. The second one is the guidelines. And the third is the neurological preterm checks. If anybody is interested, we can go to those sites and download.
Dr. Siddharth?
Hello, Prashant. Yeah.
Thank you very much for the.
Hello.
Hello, Dr. Siddharth, can you hear me? Thank you very much for the excellent presentation.
Yeah, Prashant.
Yeah, and
Thank you.
yeah, so before we move on to the next topic,
Yeah, Prashant.
one sec, I'll just play this video.
This video will
Yeah,
show
please.
accurately measure bilirubin with Bilicare. To operate the touchscreen, press the screen firmly. Use the tip of your finger or your fingernail. Let's take a basic measurement. It does not matter which ear is used. For best accuracy, avoid using the ear on which the baby lies. Once on the main screen, press the measure key. The place sensor screen appears. During the measurement process, hold Bilicare with your middle, ring, and pinky fingers on one side and your thumb on the other side. Your index finger will be used for pressing the clip's lever. You may use your other hand to hold the baby's ear. The blue part of the clip should be positioned close to the head. Once the Bilicare is near the baby's ear, press on the clip's lever. Do not place your index finger on the clip until you are near the baby's ear and ready to place the clip on the ear. Place the sensor on the upper side of the ear in the scaphoid fossa where the thickness is most consistent. Avoid placing the sensor on folds or malformations. After the sensor is placed, It is important to avoid touching the clips lever. The measurement starts automatically and takes about 2 seconds to be completed. Once finished, a beep will be heard. Gently remove the sensor from the ear. Once the sensor clip closes, the result screen will appear. It is recommended to take the measurements when the baby is still. Baby movements may alter the results. In some cases, Bilicare may encounter a measurement error. When this occurs, a measurement error screen will appear. Address the error described on the screen and try again. There are 3 options to return to the home screen. Press the next button, or the home button, or use the green button on the device. Bilicare is now ready for another measurement. Once the handheld unit is placed back in the stand, it will turn off. For further details, please refer to the user manual. Please do not hesitate to contact us. Thank you for using Bilicare.
Yeah, Dr. Prashant.
Yes, sir. Yes, sir.
Okay, see, I know that. You please announce what is the talk of the Saturday and Sunday, number 1. Number 2 is this Bilicare machine will be available from the Janwork people. Janwork people, you people can contact, or in case if anybody needs the contact number or anything, please leave a message to Dr. Prashant Gowda. He will guide you people. During the COVID time, instead of pricking or other things, this might be helpful because just minimal handling. Okay, Dr. Prashant, over to the Dr. Dr. Giridhar, SETHURAM, our next hero.
Yeah, Dr. Giri.
I'm here, sir. Yeah.
Please start your session. Meanwhile, he starts his session. Next, coming on Saturday is a neonatal skin care, basically neonatal dermatology. What will be the topic? And the second topic will be neonatal orthopedic problem. So do not miss. And Sunday also we have a very good topic on neonatal screening and recommendation other than IEM, developmental supportive care for neonates in NICU, developmental supportive care in occupational therapy and neonatal therapy is what we'll be speaking on. What can be done in NICU? Over to you, Dr. Giri. So Dr. Giri is a consultant neonatologist and associate professor at Chettinad Institute of Medical College. Thank you very much for accepting our offer.
Thank you, Prashant.
Over to you.
So my audio and video are good?
Yeah, I request you to speak a little louder.
My audio and video are good?
Please start the session. Audio and video is clear. You can start slideshow mode and you can start the session. Thank you.
So, very good evening to you all. It's wonderful listening to Dr. SIDDHARTH, his lecture on neonatal jaundice. The common indirect jaundice he was talking about. Before I start my session, I would like to thank NNF Karnataka and its members, Kishore sir, Dr. Dinakar, Dr. Prashant, for having invited me to be a part of this wonderful experience. I hope all of you guys, wherever you have logged in from, are safe and secure during this COVID times. So I will be taking forward from where Dr. SIDDHARTH left off. So I'll be talking on a slightly different aspect of newborn jaundice, not so common aspect, but nevertheless all the more important. So let's start. So this is what SIDDHARTH was referring to when he talked about newborn jaundice. The levels go up pretty rapidly, then there could be neurotoxicity. We could have a child like this with features of bilirubinemia encephalopathy, and it's going to stay for a longer time. It could be irreversible. It could cause irreversible straining of your basal ganglion. So that could result in CP later in life. So, I mean, this is a worry he was referring to. But is there any other worry this baby could be having? Let's consider this scenario here. We have a 6-month-old child who has got referred for treatment of jaundice. So this child was just a background history. This baby is born at term, weight 3.2 kilos. And this baby had the usual physiological jaundice. And the baby required phototherapy for 3 days. And unfortunately, no bilirubin levels were done at that point of time. So we don't have what was the levels baby at that point of time. And subsequently, baby continued to have jaundice, and the baby was advised sunning. And as it is, I mean, we know that sunning is good for any child. And subsequently, the babies have been seen by various doctors for complaints not only for jaundice, that the urine was also high colored, but they were reassured. This was a baby I was seen at 6 months of life. Very obvious, the baby had a distended abdomen because of hepatosplenomegaly. And I mean, the jaundice is not well visible, but if you could see the eyes clearer, the baby is deeply jaundiced. And you see the distended veins over the abdomen. This says that baby had developed portal hypertension, and varices have developed. So this baby has developed a complication entirely unrelated to what Dr. Siddharth was talking about. So this is a condition which actually started as cholestasis, but landed up with complications later. So the learning objectives of the next 45 minutes of my talk is going to be these. So I'll be talking about what is neonatal cholestasis, basically the definition, and what is going to be the disease burden, and how will evaluate a child with cholestasis. Then I'll be talking about studies which actually have a implication for the neonatologists, because we neonatologists are the ones who actually manage these babies at the outset. So, and also be briefly covering the treatment aspect. So this is what is meant by neonatal cholestasis. So if we have a total bilirubin of less than 5 milligram per deciliter, and if the conjugated fraction is more than 1 milligram per deciliter, then it qualifies as neonatal cholestasis. If the total bilirubin level is going to be more than 5, then if the conjugated fraction is more than 20% of the total bilirubin, then again it qualifies as neonatal cholestasis. So we have two separate definitions based upon the total bilirubin level, whether they are going to be less than 5 or more than 5. So a lot of things about neonatal cholestasis basically depends upon how we measure the serum bilirubin. And we as clinicians we know very well that there is a lot of discordancy in reporting of serum bilirubin across labs. When I send a bilirubin level to 5 labs, all the 5 labs end up giving different reports of both total bilirubin and direct bilirubin. So just a brief explanation of what I am trying to cover in this slide. So there are basically 4 fractions of bilirubin. We have the alpha fraction, the beta, the gamma, the delta fraction. The alpha fraction is actually the indirect fraction, or the unconjugated one. The beta, the gamma, and the delta are the direct fractions, or the conjugated ones. Delta fraction is more important because this fraction could cause more problems when it comes to starting treatment or stopping treatment for conjugated jaundice. I'll be explaining these. So the discrepancy we see across labs is not only related to the quality of the lab, it is related to the type of method that is being followed for estimating the bilirubin levels. The most common method used, I see most of the labs across India use this method, is the DISO method, the common method, and there are modifications of this, the Jendrasik Grof method, the Vanderberg reaction. Basically, this method measures these 3 fractions very well: the alpha bilirubin, the gamma bilirubin, and the delta bilirubin. But that could be an overestimation of the beta bilirubin fraction. So when we have bilirubin levels which are basically 10 or 9 or slightly on the lower level, you could see some labs using this method reporting a higher direct fraction because of over-reporting of the beta bilirubin levels. So another method, which is actually a better method, is going to be your vitros bilirubin estimation. In this method, we see the alpha bilirubin, the beta bilirubin, and the gamma bilirubin being well measured. It does not measure your delta fraction. So this delta fraction, as I told you, is a unique fraction. The uniqueness of this delta fraction is that the bilirubin fraction is irreversibly bound with albumin. So it takes a long time to get down after binding. So we could have a condition where, in spite of the disease condition becoming passive, the delta bilirubin level could remain very high. So because this fraction is not getting estimated by this vitros method, we could land up with the problem that this method could actually underestimate your conjugated fractions. The gold standard method as of now is going to be your HPLC, or the high performance liquid chromatography, where all the fractions are beautifully measured. but it's going to be very expensive. I don't know whether any labs are doing this. I think it is more done as a research level. So depending upon the method which we follow, and especially the levels of a delta bilirubin, your bilirubin results could vary. So why we need to know about this is, I think you identify the proper lab, and if you have a report which comes as saying that your direct fraction is slightly higher, look at the method, what they have used, and then decide whether that could have an implication in your practice. So next, so when to suspect cholestasis? So cholestasis is something we don't suspect initially when we come across a jaundiced child. The jaundice persists for more than 2 weeks. That is a time when we start thinking in terms of cholestasis. But our our suspicion becomes more strong when we have echolic stools or hyperpigmented stools like these. And if the parents keep complaining that the baby's urine is very high colored and it stains the diaper, and in spite of washing doesn't go away pretty easily. And some other complaints might be there, basically in a slightly older child. Basically, we're looking at poor weight gain, lack of appetite and vomiting, enlarged liver and spleen, and fatty stools or floating stools. But the first three are going to be more important when it comes to diagnosing or suspecting neonatal cholestasis. And an easy way to look at cholestasis as a screening test of cholestasis is stool color. This was something that was followed, it was introduced in Taiwan way back in 1960s and 70s. And subsequently became one of the most important screening tests for conjugated jaundice. So we have a stool color as an indicator of jaundice. So we have babies, these are the healthy stool colors, basically different shades of yellow, from deep yellow to slightly lighter yellow to brownish colors. And these are suspect stool colors. So it is always good to have this card in the postnatal follow-up booklet. And we can ask the parents to compare the stool colors against these. If their stool colors are corresponding to the suspect stools, then the babies could get followed up by the pediatrician. And as for the pediatrician also, it's better to carry these color cards in their OPD practice, so that once the babies come back to us and follow up, I mean, most of the times we look at the stools also, baby might have sparse stools at that point of time. We can just look at it, look and see whether the color is corresponding to the healthy stool color and not in the suspect stool color. So this as a test is found to have good statistical value. The sensitivity levels are pretty high. So false negatives are very less. Specificity is very high, almost negligible false positives. Good positive predictive value of 28.6%. So this is a very good test. So if you want to utilize this test, it could effectively rule out a baby having an obstructive jaundice. So what is the burden of neonatal cholestasis? So this is a report from the IAP consensus statement in 2014, which looked at all the reasons for hepatobiliary disorders in children. Out of all the reasons, 30% of the causes of hepatobiliary disorder across the childhood age group from 0 to 12 years, 30% of all the causes are because of neonatal cholestasis, and 70% are because of other reasons. So that means that neonatal cholestasis is going to be a very common problem, hepatobiliary problem in children. And in neonatal cholestasis, we have a mixed bag of disorders. We have the two broad headings, the extrahepatic or the surgical ones, the intrahepatic or the medical ones. Why I put up that cartoon there is, the medical ones are, none of the times the medical ones are, because of a single etiology, multiple insults to the liver cause this problem. Basically, the insults to the liver causing this problem are the intrahepatic ones, and the surgical ones are the extrahepatic ones. And as I told you, there could be a clinical overlap between these. I'll be talking to, about this in the subsequent slides. So this is again from the IAP consensus report in 2014 regarding the causes of neonatal cholestasis. So the majority of the causes, up to 53%, are going to be because of hepatocellular causes. So the liver insult, whatever reason it could be, is the most common cause of neonatal cholestasis. But a good number, about 38%, is going to be because of obstructive reasons, about which I'll be talking later. And 3%, 6% are because of other reasons, like ductal paucity. Some of these are undifferentiated. Among the hepatocellular, we have broad classifications. The most common ones are idiopathic ones, but infections, metabolic, miscellaneous, again, this could constitute the hepatocellular causes. Among obstructive, the one we need to rule out with emergency is biliary atresia. A chunk of these are going to be biliary atresias. Some of these are going to be even your choledoculsis. So these are the intrahepatic causes. So idiopathic, as I told you, is the most common variety. 30% of the causes. Basically, we don't find a cause, we label it as idiopathic. Infections very common, and especially when you, as neonatologists, we see a lot of infections related cholestasis. So bacterial infections, viral torches, hepatitis B and C, varicella, Coxsackie, echo, tuberculosis. A lot of viruses could cause neonatal hepatitis. Toxins, especially in those in TPN and drug-induced, could also result in cholestasis. Metabolic disorders, more and more metabolic disorders we see, and a lot of these could cause cholestasis. The more common ones being the disorders of carbohydrate metabolism, especially galactosemia. Amino acid metabolism disorders, tyrosinemia, could also result in cholestasis. Lipid metabolism disorders, you have bile acid metabolism disorders, peroxisomal disorders. We don't see much in the newborn period. Basically, if you could remember that carbohydrate and the amino acid ones, it could be enough. Endocrine disorders, again quite common, hyperthyroidism, hyperpituitarism, and they generally have a typical behavior. They start off as unconjugated jaundice and slowly transition off to conjugated jaundice. Chromosomal disorders like trisomy 21 and 18. Your miscellaneous is a very important part of intrahepatic, especially in India, where we see a lot of cystic fibrosis. We have come across a lot of babies with neonatal hemochromatosis or the iron storage disorders. PFIC is increasingly being recognized as a cause of intrahepatic neonatal cholestasis, and because after genetics have come up in a big way. And some of these disorders could be related to intrahepatic bile duct paucity. There are two different distinct entities there. The syndromic ones are the Alagille syndrome, the non-syndromic ones are other ones. So among neonatal hepatitis, with more and more therapeutic armamentarium going up, more the genomics coming up in a big way, the proteomics coming up in a big way. So a lot of conditions we're able to recognize. Previously unrecognized ones are becoming recognized now. So previously the idiopathic group was around 65%. So the recent number has come down to around 25% because genomics have identified a lot of things that were not diagnosed earlier. And many more syndromes are being recognized now. And we should be aware of this one, which is very common in the Indian population, especially the PFIC. It's called progressive familial intrahepatic cholestasis. And we have there are 5 ones, but these are the 3 ones which are problematic. Basically, this disorder, there is a problem with the pumping of the bile salts into the canalicula. So we have 3 distinct varieties, PFIC 1, 2, and 3, depending upon which pump is getting involved here. And so the PFIC 1 and 2 could present in the early, newborn period also. So the distinct, the distinct issues which we see with PFIC is there is a lot of itching in these babies, and also there is a progressive liver disease. So babies' liver get involved pretty rapidly in these conditions. So these babies land up most commonly with requirement for transplants. So let's look at the extrahepatic causes. We have seen the intrahepatic. Let's look at the extrahepatic causes. And this is a small cartoon to illustrate what I'm going to say here. In the extrahepatic causes of cholestasis, as I told you, the most common one is involving your bile duct. So there could be a problem with the bile duct. So this is called extrahepatic biliary atresia. And a lot of things could result in EHBA. The most common ones being inflammation. Some of this could be genetic, especially polymorphisms in the HLA B12 area. Toxins, both exogenous and endogenous, could result in EHBA. Immune insult to the biliary tree could result in EHBA. Again, infections are common here. Some unique infections like reovirus type 3 have been related to at least 80% of babies who are infection-related EHBA. And this is the classification, proposed in 1976, modified in 1991. Unfortunate thing about ESBA is, most of these ESBAs are not correctable, and they will require transplantation at some point of time. Your portoenterostomy could buy some time, but they will require transplant. Around 83%, the type 3 varieties are going to be more common. They're not correctable. But fortunately, if your child lands up with the type 1, type 2A, or type 2B, it could be potentially correctable even with portoenterostomy. So other causes, there's something called the choledochal cyst. In the EHBA, the biliary tree becomes atretic. In choledochal cyst, it becomes ballooned out. So polydactyl cyst is another important recognizable cause of extrahepatic cholestasis. Sometimes cholestasis could be because of sludging of bile, very common in the newborn period, especially when there is heavy intravascular hemolysis. We have settings like RH incompatibility, ABO incompatibility. The hemolysis is very hectic. Then it could result in sludging of bile and it could result in cholestasis. So this is called inspissated bile syndrome. And lastly, any stricture in the bile duct, stenosis in the bile duct, or if it was spontaneously perforated because of some reason, all this could result in extrahepatic cholestasis. So let's look at EHPA a bit closely. There are two distinct presentations. The embryonic one, which has very early onset, even at birth, the baby could be jaundiced because the insult has happened in utero itself. And this is the most severe variety, because no bile duct remnants are there. And this could have associated congenital anomalies because, obviously, because in utero insult, anomalies could be up to the extent of 20-25%. The other variety, thankfully, more common is the perinatal variety, 65%. So this happens, babies are not born with the abnormal biliary tree. The insult could have happened in the perinatal period or even in the immediate postnatal period. So we have babies initially presenting with normal stools, gets transitioned to ecolic stools, and there the babies generally are jaundice free for a period, and then they become more jaundiced. So here it could be potentially correctable because remnants are found and there are less likely to have any congenital anomalies. So why should we understand these two subgroups? The distinction between your extrahepatic and intrahepatic causes, why is it more important? Because it has an implication in decision making. The obstructive ones, the current recommendation is to get a surgery done less than 60 days if you want to improve survival, especially a biliary atresia. Hepatocellular ones identify the treatable causes because the earlier we treat them, the better it is for the child. So it is very important that we identify whether it is going to be an extrahepatic cause or an intrahepatic cause. So if we don't do that, we could result in consequences of cholestasis. This is what happens when cholestasis progresses. We have an diagram of the biliary tree which drains into the small bowel. So once there is an obstruction, the bile does not come out into the small bowel because of any insult to the liver or the biliary tree. What happens is a lot of bile builds up in the liver, some of it in the biliary tree also, and none of this comes into the small bowel. So what we have is the bile that is there in the liver, it starts getting translocated into the bloodstream. So we could end up with a baby who is deeply jaundiced and urine color also becomes high colored. And of course, because bile does not enter the small bowel, your stools are likely to be ecolic or hypopigmented. So the consequences are two ways here. Because of bile regurgitating from the liver into the into the vascular system, we have a lot of symptoms related to that. So bile acids going into the systemic circulation could result in pleuritis. It could injure the liver also. Cholesterol, because the bile is essential for your lipid metabolism, could result in xanthomas. Copper, which is excreted again through the bile, could result in hepatotoxicity. And because of less bile in the gut, what happens is a lot of malabsorption could happen. So baby could land up with growth retardation, diarrhea, and calcium loss. Of course, because fat-soluble vitamin deficiency also could occur. So we could result in a child with ADEK deficiency, resulting in night blindness, rickets, neurodegeneration, and bleeding manifestations. So end of the day, if we don't recognize this untreated, this baby could land up with what we saw in the first slide. The baby has cirrhosis and portal hypertension with the distended veins. So that is, in spite of there being clear recommendations that this should happen at the Phaya-Brigand place, this baby should be recognized, referred to a liver center before 2 months. It seldom happens like that because delayed referral is the norm rather than the variation. So it happens when identification and referral happens still at a very road pace. So this study from 2005 and 2009 from SGPGI, Professor Techa et al., who actually have looked at the onset of symptoms. In spite of symptoms having onset at around the 3rd week of life, babies are presented to the liver center only by around 3.5 months. And ranges have been up to 5 months even. So the mark of 2 months is gone here. So this is the experience from SGPGI. I think a lot of other centers are also experiencing this. This the data from 5 centers about when the baby is presented to them. I will see that most of the babies presented only at the end of 3rd month. So this says that even in spite of there being clear instructions that don't miss such jaundice, it is seldom happens. This jaundice tends to get missed. It happens at a road roller's place, and the babies land up at the center very late after the 2nd month. So this is the first baby which you had seen, the baby who had abdominal distension and the distended abdominal veins. So this baby had biliary atresia, undergone portal enterostomy, and this kid has grown now, but he is now around 11 years. You see the child here is still, the eyes are pretty yellow, and what we see is this child is requiring a liver transplant now. So at least we're able to buy time. I think the liver transplant could be done at a slightly later age once it comes through the system. So at least portal enterostomy, getting it done below 2 months. When what happens is the babies start growing well, the symptoms become slightly better initially, and maybe there could be some time which you could buy for liver transplantation. So for the neonatologist, these are the take-home messages. The jaundice, high colored urine, ecolic stools, get a bilirubin fraction done, which confirms cholestasis, identify the treatable causes and the complications, and give vitamin K and refer. So this is the approach that has been proposed by the IOP consensus statement. So clues. So towards etiology, what are the clues are generally there? If there is a history of consanguinity, or your sibling has had jaundice, there's a family history, then we think in terms of genetic disorders. If there is a cholestasis in pregnancy, especially the mother has had an acute fatty liver or cholestasis, then that could be a PFIC in the baby. If the baby is having lethargy, weak cry, and infrequent feeling, think in terms of hypothyroidism. There is a bad obstetric history, a flu-like illness during pregnancy in the mother, think in terms of intrauterine infection. And if there is setting of ABO or RH incompatibility, of course, it could be an isoimmunized shell landing up with high hemolysis and your sludging of sludging in the gallbladder. So again, extension of the clinical clues. If a sick child, think in terms of sepsis, torch infections, and IEMs. The baby is dysmorphic. Trisomies, the trisomy 21 is easily recognized. And Alagille syndrome is another one which I would talk later. If the baby is having a cardiac murmur, think in terms of Alagille, which could be associated with your pulmonary stenosis murmur. Rubella is another one, PDA is associated with that. Cataract, galactostemia, and intrauterine infections. Midfacial defects are there, then there could be we could think in terms of hyperbilirubinemia. So simple clinical guide is this. We have a sick child who was presented with cholestasis and the stools are pigmented. Do these investigations. Look at urine for reducing substances. Do the gall assay. Do the blood and urine cultures and malarial parasite, which could be common based upon the area the mother is from. Do the torch serology and the alpha beta protein. Look at urine succinyl acetone. Basically, we want to look at tyrosinemia and serum ferritin, lip biopsy, MRI abdomen. This I would talk in the subsequent slide why we need to do this. And if we have a well child, then when we have more time with these children, so the first thing that we need to ask is, does the urine stain the diaper? The answer is yes. And the second is the stool color. So compare the stool color, and if the stool color appears a bit suspicious, keep looking at it again and again, and keep asking the mother again and again, and confirm the suspicious, or it is still the mother is not sure and you are also not sure. It's better to actually err on the safer side, get the bilirubin fractions done, and ultrasound to rule out your surgical causes. Basically, you are looking at your biliary atresia, choledochal cyst, strictures, or sludging, and get a liver biopsy done. Your HIDA scan, basically your HIDA scan, right now it has come a little bit low on the hierarchy because it is not a very easy test to perform, not easily available. It requires a lot of priming with phenobarbital, which is not advisable in these children. So if we have an option, better go for liver biopsy, because HIDA scan, essentially, if you have the tracer entering the small bowel, it says that it rules out surgical causes. But if we don't have the tracer entering, it doesn't rule out anything. So the negative predictive value is not there. So better go for liver biopsy if you're still worried about the HIDA scans being conclusive. So let's talk about what neonatal cholestasis means for the neonatologist. Basically, for the neonatologists, these are the 4 important things we need to keep in mind. GALD, which stands for gestational associated liver dysfunction. TORCH, we know that, metabolic disorders, and TPN or prematurely related cholestasis. Let's look at a typical case which we managed pretty recently. This was a para 2 live 2 child at 38 weeks, weighing 3.2, good weight baby, 3.2 kilos. And an antenatal scan had showed just before delivery had shown a slightly enlarged echogenic liver, minimal ascites. And this baby, I mean, they didn't give much when focused to the scan. So this baby was delivered, I mean, after the usual normal delivery. So this baby was unfortunately depressed at birth, was ventilated. And the baby developed, had hypoglycemia requiring dextrose infusion at 8 milligram per kg per minute. Baby was also noted to have hepatomegaly, which was picked up in the antenatal scan also. But what we saw was there was progressive increase in jaundice from day 2 to day 5, and gradually the jaundice became from indirect, it went down to direct. But the stools were, I mean, still meconium, and they transitioned over to the yellow color. This baby had a lot of problems. The baby was difficult to wean from the ventilation. Asphyxia was basically because the lactate initially was normal. So the baby has not developed, had a very significant perinatal asphyxia. So we was finding it difficult to get the baby out of the ventilator. And there was increase in edema which happened over the days. Bleeds were happening. And on evaluation, the INR was pretty high. It was always remaining more than 2. Baby required multiple fresh frozen plant spas. And platelets were touchwood normal, and this only came to the low normal levels, the mild thrombocytopenic levels. Further investigation showed that albumin levels were pretty less in this child. No reason, because baby was 3.2 kilos. And the OTPD levels were slightly elevated, 50 to 75 international units per liter. And that was the time we suspected something could be amiss. We had the ferritin AFP levels done. The ferritin levels was quite high, 2,890 nanograms per ml. I mean, for people who don't know, the reference levels are from 25 to 200. So anything more than 200 is high ferritin. 2,890 is quite a high level. The alpha-fetoprotein, again, levels are up to around 380,000 nanograms per ml. And levels in a term child should be less than 80,000 nanograms. That is the reference cutoff. So this baby had some issues with the liver. So this was, again, we go to the algorithm which we saw earlier, a sick child. This was a sick child, and the baby had pigmented stools. So this baby also had a acute liver failure. Baby had elevated INR, so low albumin, increasing bilirubin levels, hepatomegaly, ascites. So we followed the algorithm which we saw earlier. So we did all these investigations which we have seen earlier. So this baby had urine for racing substances done, gallput assay, cultures, malarial parasite, TORCH serology, succinyl acetone. So the first 2 basically rule out galactosemia. The subsequent 3, we ruled out malarial parasite, the blood bacterial sepsis, and your viral sepsis. Urine succinyl acetone we measured, which came out to be normal. So we ruled out tyrosinemia here. So we are left with this one, ferritin, lip biopsy, and the MRI abdomen. So let's see what we did. We did the ferritin levels, which we saw earlier was quite elevated. We took a lip biopsy, and we stained it for iron, which came out to be positive. The Prussian stain turned out to be positive for iron. Subsequently, this baby had an MRI done also with much difficulty. There was reduced signal in the T2 thing, and the radiologist interpreted it as iron deposition to the liver and the pancreas. So we have a baby who has an extra hepatic iron deposition. This condition is called neonatal hemochromatosis. Because this baby has had an antenatal onset, because we had an abnormal fetal ultrasound. We remember that this baby ultrasound showed actually problems. There was ascites, there was hepatomegaly. So this was an antenatal onset problem. So we are descending with the condition called GALD. And most of these conditions, they tend to get picked up pretty late after the end of first week or second week only. They tend to get picked up because we don't think of this in the first thing. It's a condition which actually is very akin to your RH isoimmunization, where antibodies from the mother, it comes into the baby, destroys the baby's liver antigen and results in liver insult. So we could have a baby who presents with cirrhosis pretty early and renal failure. So this baby, as per recommended guidelines, underwent exchange transfusion, IVIG, multiple dosages, but still baby did not recover, eventually succumbed after going to the liver center. So this is a very condition which is potentially dangerous for the child. It could be fatal also. So we need to recognize this as a neonatologist pretty early. So clinical pearls here are these. These are the common ones which cause liver failure, because these are the ones which call cholestasis and liver failure. GALD is the most common one. Viral infections are also common. HLH and mitochondrial hepatopathies are not so uncommon. The unique thing about GALD is the hypoglycemia, which can be there. Hepatosplenomegaly is not that common. It could be mild, not to the extent which we see in viral infections. Your biochemistry could give us the clue there. The AST, ALT level, in spite of there being fulminant, liver failure, they're usually in the, in the low normal or the normal zone. They're generally less than 100. So in other conditions, we have very high AST and ALT. Your ferritin levels are generally very, very sky high during viral infections, more than 20,000 nanogram per ml. But in this condition, they're elevated, but they're generally less than 7,000. The alpha-fetoprotein, again, it says that there's been a liver insult, is also pretty high. It's a reverse of ferritin. It's very high in this, and it's not that high in the viral infection on HLH. So there are ways where we could suspect this. So the fetal onset, mildly elevated ALT levels, your ferritin being elevated, not much, very high AFP levels, and the deposition of your iron in your extrahepatic tissues, especially the lips and the pancreas, all say that this baby has had a GALD to treat for GALD. So torch infections, especially your CME and herpes, are very known to cause liver failure. So if there is a clinical setting, you have a sick child with liver failure, think in terms of cause. You know what are the stigmata for torch. So this is a 35-day-old girl with jaundice. We see a protruding abdomen, a protruding tongue, your umbilical hernia there. So this baby obviously has features of congenital hypothyroidism. This could be picked up with the newborn screening. At least it has not been done earlier. When you see features like this in a baby who presents with cholestasis, get a thyroid profile done. This is a 25-day-old boy with the newborn jaundice and a cardiac murmur. This is the phenotype of the child, face of the child. We see a very broad forehead, slightly deep-set ears, a pointed chin, upturned nose. So nothing very alarming here. But we look at the X-ray, the vertebra, we see that there's a butterfly vertebra there. You see the butterfly vertebra nicely. It has been shown in the arrow there. So this baby has Alagille syndrome. The murmur is because of the pulmonary stenosis. So very common scenario in NICU, X28 weeker, 770 gram, day 28 of life, where the baby starts having pale stools and dark urine, and the direct bilirubin fraction is 7.3. And the history is the baby had a Sepsella sepsis and being treated for that, and baby is receiving TPN for medical NAC. So a very common scenario which we see in the NICU. So this baby has had something called the parental nutrition associated liver dysfunction. So the treatment here is, the first thing we do is, once we see the report of very high direct bilirubin, we reduce the lipids. So we bring down the lipids to less than 1 gram per kg per day, but that could be slightly counterproductive because your essential fatty acid deficiency should start coming up. So we need to balance this against the deficiency. Once your bilirubin levels start falling, go up a little bit. So we are right now using the SMOF lipids or the fish oil based lipids. SMOF stands for soybean oil, medium chain triglycerides, olive oil, and the fish oil based lipids. Basically, these are the ones which have a better omega-6 to omega-3 ratio. So this could have potentially, hepatobeneficiary effects. They could bring down the direct bilirubin levels. UTCA, your ursodeoxycholic acid, could also do that. And of course, enteral feeding and breast milk. And very importantly, treat the insult to the liver, treat infection. And there are a lot of things being tried out now, especially the glucagon-like peptide 2, very expensive at the research level. So let us look at last few slides are going to be on the medical management of cholestasis. So the one thing that we need to look at is the growth of the child, because the better the growth of the child, the earlier is the baby is going to tolerate all your procedures pretty rapidly. So we should provide more calories to this child because the babies lose calories in their gut. So 150 to 200 kilocalories is what is being recommended, and proteins are also has to be high, especially when this is not only thing is look at the encephalopathy. The baby is very encephalopathic. You might need to come down on the protein load. And the baby is not taking orally well, then try out nasogastric feeds. TPN also could be an option. And very importantly, as pediatricians, neonatologists, we should do regular growth monitoring. So these are the nutritional supplementation. The macronutrients, the fats, carbohydrates, and proteins need to be supplemented. The micronutrients also, the vitamins, the fat soluble, the water soluble ones, and the minerals like calcium, iron, zinc, and magnesium. So regarding the macronutrients, the fats are the ones which is always a problem because your long chain triglycerides are not absorbed well because of lack of bile in the gut. So we need to give more of medium chain triglycerides because they are absorbed directly into the bloodstream and they don't need bile. So right now formulas are available, your 60% MCT based formulas with essential fatty acid, linoleic acid. It's going to be the preferred substrate. But if the patient cannot afford it or the baby is otherwise doing well on breast milk, then you could try giving a little bit of coconut oil which contains 65% MCT, and even simple MCT oil is right now available. Carbohydrates, don't forget carbohydrates because carbohydrates also have to form a part of the diet. 60% of the calories has to come from carbohydrates. The proteins also need to be supplemented. Basically, a part of the calories should come from protein. Your branch chain amino acids and the casein-based formulas are more, proteins are more preferred. Only thing is, if child is encephalopathic, ammonia levels are quite high, then you could consider a reduction in the protein intake. And breastfeeding is the best thing even in this situation. Only thing is, the baby is not gaining weight on breast milk, then try out your giving your coconut oil or a similar MCT oil. The baby is not tolerating breast milk because of some scenarios like your galactosemia, then it could consider the formulas. Micronutrients, of course, there are guidelines being given by the pediatric gastroenterology group of Indian pediatrics. So we have intakes of A, D, E, and K, and water-soluble vitamins, calcium, phosphorus, zinc, magnesium, and iron. So generally, the dictum here is more than the RDA, give 2 to 4 times more than the RDA for your fat-soluble vitamins and 2 times more than the RDA for your water-soluble vitamins. So that's what we are looking at in terms of micronutrients. Specific treatments, baby is having pruritus, which could be presenting in a slightly bigger child. Consider Utka, rifampicin, and phenobarbital. There are variceal bleeds, propranolol, ascites. You consider salt restriction, diuretics, and albumin infusion. Baby is having coagulopathy, treated with vitamin K and FFP. And we have etiology of biliary atresia, go for early portoenterostomy, galactosemia, soy-based formula. And we have tyrosinemia type 1. We have now NTBC. And desicinone available, so 0.6 milligram per kg per day can be tried. So this is the last slide. These are the take-home messages. Ali, I know most of you are already home. So these are the key messages from my talk. So neonatal cholestasis is not uncommon. Think in terms of neonatal cholestasis. Once your bilirubin levels are not coming down for the first 2 weeks of life, any jaundice more than 2 weeks require consideration to rule out cholestasis. Always during your postnatal visit, look and ask for the stool color. Always ask for fractionated bilirubin levels if you have the baby being evaluated for hyperbilirubinemia after 2 weeks. And early referral and less than 2 months is critical because we are going to talk about EHPA. The earlier, the better for the baby. So this is the last picture. So this is a message regarding the EHPA, which the child wants to give the doctor and the parents. So this is from the appeal from the pediatric gastroenterology specialty of Indian pediatrics. So which basically says that refer me early. So thanks for your patient listening. Over to Dr. Prashant.
Yeah, thank you, Dr. Giri. And Dr. Gautam Suresh from Texas has a message saying that please convey my feedback to both the speakers. The 2 talks were excellent and both were excellent teachers. All right. Anyway, so moving ahead with the discussion part, we have a lot of questions. I request Dr. Ashwich Sriram.
Yes, sir, I'm here.
Yeah. So kindly coordinate. Meanwhile,
Yes,
I have few questions on Facebook as well. First, you start, Ashwich. After that, I will post the Facebook question. I will tell.
Good evening, everyone. I'd like to thank both our speakers on behalf of NF Karnataka for having taken up this invitation on our behalf. And it was a wonderful session. And as both of them have put it, one is a very more commoner problem, another is something which is uncommon. Both have presented it equally well. Now I'd like to go ahead with few questions. First, going to Dr. Siddharth. Can you hear me clearly?
Yeah, yes, sir.
You did mention regarding exchange transfusion. So is there something like you need to finish exchange transfusion within a given amount of time?
Yeah, so it's recommended to do it within 3 hours. The total procedure is between 2.5 to 3 hours. But are you talking about starting exchange?
Okay. No. I'm talking about finishing the procedure.
Right, yeah, within 2.5 to 3 hours.
Oh, okay, sir. Does it make any difference, like if earlier we finish, faster we finish, the outcomes are better, anything like that, or later we do it, means it takes a longer duration?
No, there is no research on that, but if you do it faster than the recommendation, there are more likely chances that you have metabolic disturbances. So I don't think that will be advisable at all to do faster exchange.
Okay, sir. Now, most of the places, like most of the blood banks, don't tend to keep nowadays whole blood. We find it really difficult at few outskirts and here and there. So if whole blood is not available, how do we go ahead?
So you need to mix both the PRBC and FFP. If a blood bank is able to do it, they will do it in a sterile manner and give it to you, and that's the best scenario. But if they're not going to do it, then you have to do it in the urine. And the hematocrit of the end product should be around 0.5. So it depends on the packed cell hematocrit as to how much FFP that you need to mix. Usually it's between 1:5 to 1:7. 1 of FFP and around 5 of PRBC will get you an hematocrit of about 50%, which is what we want for exchange. Hello.
Hello, Dr. Shian. Yeah, Dr. Shian. All right. I think we lost Dr. Shian. Dr. Shian, you're there?
Yes, sir. Yes, sir.
Yeah.
Okay. I hope he has answered it well enough. I didn't get the last. Okay. A few questions have come in regarding the use of bilirubinometer to us. So one thing is regarding cutoffs for the bilirubinometer values. Any specific guidelines what to do with values at what hours of life?
There are nomograms published from all around the world, and I just showed you one graph from Indian data. That's from Gujarat.
Yes, sir.
TC. These are only nomograms. They tell you the normative values, and they don't include babies who have increased risk for jaundice. So right now, our guideline is still to take TCB as a de facto TSB value and plot it on the AAP chart and go ahead with your treatment. And if it is more than 12 or more than 15, depending on what kind of manufacturing it is, we need to check with a serum bilirubin.
Okay, sir. Any role of cord bilirubin, like in identifying the high-risk babies which might require phototherapy in the future, anything like that?
Yeah, absolutely. Then if you have a baby who's at risk for developing jaundice, like mother was identified to have antibodies, or you think it's an Rh negative disease with ICT was positive, we'll go ahead and do cord bilirubin. If it is less than 2, you're kind of safe. If it is going near 4 to 5, then there is trouble, and we need to keep a close watch.
Okay.
Repeat bilirubin early.
Regarding LED lamps, okay, there are few machines, they do come with knobs to adjust the intensity of the phototherapy light. So any recommendations on those? Anything needs to be done?
For all, even if you don't have a knob, we need to measure the radiance levels. So many units don't measure, but it is better that we measure, because if we say intensive and the baby doesn't get intensive, then it's a problem. So it's always better to have machines which have a radio meter attached to it, so that you can measure the radiance.
Those mobile apps, can they be used to assess the intensity of the bilirubin machines?
There is some correlation, and there is one study. Yeah, I mean, up to 75%, I think 0.7 is their correlation. It works okay, I think, in certain low bilirubin settings. But yeah, more studies are required on it.
Regarding the lights, again, LED machines, sometimes they do come with only blue, only white, and blue and white. So which to use?
Blue. Blue is the best. LED blue is the best.
Blue.
Only white and daylight
Okay.
white. Are
Why those
in
machines with the white light then? Are those recommended or?
In fluorescent lamps, white is used along with the blue to help reduce the glare and the nausea, because they cause kind of motion sickness to caregivers. But otherwise, blue LED.
Last one, I won't trouble you much.
No.
Regarding the use of eye bands between this and that, anything which you'll specifically advise?
No, we actually use a very local one, which is made in Kerala, because they actually fit very well for us. They also supply preterm eye bands for us. It's called Ibis. But yeah.
Few questions I'd like to now address it to Dr. Giridhar.
Yeah, please.
So can you hear me clearly?
Yeah, please.
Yeah. You did mention the stool card. Anywhere are listeners from where they can download this card or anything? Is it available?
No, it's freely available. In fact, if you could go Google a lot of, and I think the Pediatric Gastroenterology Association has also come up with its own stool card. It has been validated in a lot of places. Even in, I'm aware of it getting validated in Chennai also. So I think it is freely available. You can approach your local IAP body and they should be able to share it with you. Am I audible?
Yeah.
Yeah, okay.
Any scoring systems or anything which will identify the patient, and patient which will be requiring early high risk patient which will require a transplant?
No, just can you come up with the question again? Your voice was not that clear.
Ashwij, your voice is breaking. Repeat the question again.
Yeah, any scoring system which will help us identify the patient which requires an early referral to a transplant center.
Yeah, there are scoring systems, but I was more concentrating on the neonatal aspect, because my aim is to actually send the baby to the gastroenterologist. So hepatologist, he will take a call regarding a transplantation. So there are scoring systems. I think you can look it up, sir. I'm not aware of the intricacies of the systems.
Okay, right. Regarding your neonatal HLH.
Yeah.
Again, we do come across them quite rarely, though. Yes, but how are the outcomes with those neonatal HLH? Are we providing them there is a scope that they would survive, or mortality is very high?
Yeah, mortality is going to be very high, provided that your HLH is because of your infections. If you treat the infection, then you could you can give some drugs to many immunosuppressants to reduce the inflammatory action. Then you could land up with, good survival. But of course, if you have a baby with HLH, the reason being that it gets picked up pretty late. The moment we start thinking of this, already his baby is quite sick. So that is why the mortality is quite high, because we don't, at the first instance, we don't think in terms of HLH, your galled and other things and all. So this mortality is going to be pretty high in these situations.
You did mention MCT formula available. Any specific brand which you might say that is,
Am I allowed to talk about brands?
It's fine. You can.
Okay. So Pure MCT is one brand which is available. I think it's an Indian company's marketing. I'm not aware of which company is that. So we could use the Pure MCT.
Pure MCT. Okay.
Yeah.
You mentioned extrahepatic biliary atresia. You did mention the tests. like if not the gold standard, which is the best test that you can help to identify extrahepatic biliary?
No, gold standard is going to be your liver biopsy. If you otherwise, I think a good experienced sonologist should pick it up. I think we seldom see the triangular cord sign, which is actually told to be a very specific radiological marker of thing. What we generally see is your distorted gallbladder, your gallbladder mucosa being slightly thickened. And the reason we don't pick it up commonly in ultrasound is one is a sonologist is not experienced to pick it up. Second reason is a lot of times we don't fast the babies for 4 hours before we do the test. I think we need to fast these babies for 4 hours so that we are able to see the gallbladder morphology pretty clearly before we are commenting. So most of the times, I think if this ultrasound is suggestive of thing, then we could talk to the hepatologist and let him decide on whether this baby is not to be go on the HIDA scan. Because HIDA scan, as I told you, because the once the tracer enters the small bowel, it rules out the obstructive causes. But if it does not enter your small bowel, still we are lost. We don't know whether it is hepatocellular or obstructive. So again, we'll have to go for a liver biopsy and cholangiogram. So that is the reason biopsy will be the better option for actually ruling in or ruling out these conditions. Now, I think because genetics are freely available, you have the clinical exome sequencing is coming up in a big way. We have a good genetic panel. Most of the reputed genetic labs offer this. I mean, so we could, talk to the parents and avail of these facilities also.
The last slide my question. You said at 14 days of life, the baby, what happens in areas the baby is discharged? You can hear me?
Yeah, now we are clear.
That is better. You can repeat the question again.
Can you hear me?
Yes.
Yeah. Most of the time, what happens is once the baby is discharged, you next see them only follow up at next vaccination itself only. That is at 45 days.
Yeah.
So usually in between, really, how should we fill up that gap? How do we go ahead with that baby which is presenting at 45 days finally? What should we
see? If you look at the WHO criteria, it clearly says that don't discharge the first 24 hours because we are actually looking at very early discharge for because of crowding in our wards. So why we want to discharge after 24 hours is we have to ensure that the baby has a good meconium passage. Subsequently, it is a good practice to actually print your stool cards on the postnatal follow-up booklet so that we can ask the parents to follow it up. And most of the times, even don't ignore jaundice. We know about the predictive value of the visual assessment. So if your parents are themselves, you tell them that the baby is appearing yellow, come back to us. Okay. And if you look at the WHO criteria, we have a follow-up visit because most of the times, even SIDDHARTH was mentioning about the AAP guidelines, depending upon where the pre-discharge bilirubin is, you call them up on follow-up. We don't tell them that. So the first follow-up visit is basically for ruling out whether the baby has become passive, jaundice has become passive. Baby is still appearing to be jaundiced, we need to have a bilirubin fractions. So that is the reason, and subsequent follow-up will depend upon what is going to be the value on this follow-up. So it is not that only once we are effectively sure that the baby is not going to land up with jaundice, then only we tell them that they don't need to come back and we call them at 45 days. So, and in between also give them the clear message that the stool needs to be watched. And if someone mentions that the baby is jaundiced, please come and show it to us. So that is how we pick it up.
Okay. Last one to you. In Indian scenario, what is the mean age by which the child needs liver transplantation after a Kasai procedure?
See, it all depends upon the degree of biliary tract involvement. If you have a very severe biliary tract, very few remnants are remaining after remaining, and the enterostomy is not, portoenterostomy has been done, still the baby is landing up with very deep jaundice, failure to thrive, then I think it all depends on the availability of the liver. You are registered with the registry. You are on the list there. So availability of liver is transmitted through the committee and that should also be available. So, I mean, I was fortunate to have been associated with an institute that did liver transplantation, that is Global Hospital in Chennai. That was around 4 years back. So, I mean, we have seen babies who have got operated on fourth month, fifth month as transplantation. So, and that is a center which has done the maximum liver transplants in India, right? Dr. Mohammad Rila and his team. So, it all depends upon the presentation of the child and the availability of the auxiliary graft also.
Sir, any raise of hands? Anybody else would like to ask questions?
There are a few questions.
Over to you, Dr. Prashant, sir.
Yeah, there are a few questions. What is the nutritional concept? They're asking about the vitamins in direct hyperbilirubinemia. Dr. Giri.
Yeah, I think earlier we were giving a lot of vitamin A, vitamin D, and vitamin K to these children. See, if you look at the current recommendation by the IAP, the 2014 recommendation, and also a bit of the ISPAGAN recommendation, it starts at the physiological level. Okay, so general recommendation is if you can give around twice the RDA or up to 3 times an RDA, it should be okay. So we don't now give monthly injections of 50,000 units of vitamin A, vitamin D, and we don't have vitamin E. And the problem is we are able to source out injection vitamin D, but vitamin A availability, Aquasol, parenteral is seldom available. It's very difficult to get it also. So right now what we do is we choose a good multivitamin brand which has a good RDA. They give it at 3 to 4 times the RDA. So that should be enough. But keep evaluating your child. Look for conjunctival cirrhosis. Look for features of vitamin D deficiency, vitamin E, neurodegenerative problems. And if you have those features, evaluate for it, and then you start giving higher doses of vitamin A, D, E, and K. K, at least, it's a good practice for babies who present with liver failure to actually administer them 2.5 to 5 milligrams intramuscularly once a month.
Okay. One more question. There is pruritus in a neonate. What oral medications can be given?
So diagnosis itself is very difficult. I don't know. I'm not well versed with diagnosis pruritus in a neonate. So the baby could essentially be presenting to you with irritability. So I won't. I don't know whether we can attribute pruritus to irritability also. So the baby only. I was talking about the later child only. So for pruritus, people have looked at UTCA. People have looked at rifampicin. People have looked at even doing a biliary diversion. But depends upon. I think UTCA. We would have most of these babies are already on UTCA. So I think that could reduce your pruritus a little bit, but don't talk about pruritus in the newborn period.
Okay, what is the differential diagnosis to think of in terms of IEMs for direct common ones, which would clash with the common IEMs problem with direct hyperbilirubinemia? So
I was talking the baby is a sick child. Then I think metabolic. You're talking about galactosemia. Talking about tyrosinemia. These are the two ones on metabolic encephalopathy, mitochondrial encephalopathies. These are the ones which actually present with severe liver failure and neonatal cholestasis. So this could be identified. Mitochondrial ones are slightly difficult because you need to have that lactate pyruvate molar ratios. And now I think the mitochondrial genome has been sequenced, so you could get it done, but the report could be coming in a bit late. So these are the 3 common ones which has to be picked up by the neonatologist. Other things actually they present with cholestasis, but they don't give us more. They're not sick babies. They're relatively okay babies. Only if the insult stays on for a very long time, it's going to become problematic for the child. So don't forget the galactosemia and tyrosinemia and your mitochondrial diseases, which could present with fulminant liver failure with cholestasis.
Okay, so we have IDA scan like that. Any ultrasound signs which
that was I was talking earlier, because ultrasound basically rules out your surgical causes. So if you have even I tend to put this babies a little bit of IV for 4 hours, then get the ultrasound done. The sonologist experience is more important here. The sonologist says that your gallbladder morphology is distorted. The length of the gallbladder is going to be less than 1.9 centimeter. And you have some sort of the mucosal lining is not very regular, then all these signs could say that the baby could be having a EHBA. So colorectal cyst can be picked up. Most of the radiologists pick it up. Your sludging in the gallbladder, your blockade of the biliary tree can be picked up. So I think the experience of radiologist plays a role here. Basically, you are looking at ruling out surgical causes, and your ultrasound signs could just tell you that there could be a liver insult. So you could look at echogenic liver, compare that with the heart, echogenicity of the heart. It matches that. It say the liver is echogenic. We could look at a biliary radicals, some dilatation is there. Good. So all these things could give us some clue that there has been a liver insult. But if you want a more specific etiology, you need to go for the next test. So ultrasound is basically for ruling out your surgical causes, that is your extrahepatic causes.
Yeah, I mean, just summarized as ghost sign, a normal bladder length should be.
Oh, you are the expert, sir. I think.
Absence of 3 layers, that is muscularis and serosa. Anyway,
thank you.
Yeah, thank you, Giri. This question is for Dr. Siddharth. At what age does the level of bilirubin becomes on par with the adult level?
It takes at least 2 weeks because the
adult is around 1
enzyme.
Yeah, 1. Yeah.
The maturation of the enzyme takes 14 days. So the levels start to fall below the to the adult levels by around 3 weeks.
Okay. What is the indication and timings of immunoglobulins used in RH and ABO incompatibility?
Like IVIG?
IVIG, yeah.
So as I was saying, the evidence is quite poor. So there are only very small studies and there's a lot of bias. But if we are going to give, because there is nothing else that we can do to prevent chronic risks, and it's going to take time for exchange, in addition to intensive photo, we'll start IVIG at 0.5 to 1 gram per kg. And then we give that 1 day, you can repeat it, repeated second dose also if you need. That's the dosage.
Okay, and I think somebody has raised their hands. Yeah, before that, can you tell us the key differences between the pathological and exaggerated physiological? Suppose if on day 3, if both the values are 15 or 16, how to think of whether it is pathological or exaggerated physiological?
Mostly the rate of rise will be different for both. So if pathological jaundice will have a rapid rise, so if you measure a subsequent bilirubin, you will know that the level is going faster up. If that is the day 3, day 4, unless you're checking for anything else, like if you're doing your counts and smear and you see some hemolysis, and that's an indication that you are having pathological jaundice.
Okay. I think Dr. Naresh has raised the hands. Dr. Naresh?
Yes.
Yeah, please ask the question. Dr. Naresh?
Case in phototherapy, for which is single surface or double surface phototherapy.
Can you repeat the question?
Sir, what should be the level of bilirubin level for single surface phototherapy or double surface phototherapy? And question number 2, can we expose the scrotal area to the phototherapy unit when the serum bilirubin is very high?
Okay, for the first question, the standard phototherapy will be around 8 to 10 radians, and that needs single light. And if for the phototherapy, the indications will be that even under phototherapy, the bilirubin is not falling. The bilirubin is approaching exchange transmission levels, or the rise of bilirubin is more than 0.5 gram per hour. So if this is there, then you change to intensive photo. Intensive photo means you use either 2 lights, double surface or triple surface. So that is when we change to double surface lights. So ideally, we need to measure your radiance even when you start double surface, just to ensure that we actually increased our intensivity rather than just thinking that we have increased it. The second question. Yeah. So the CPS guidelines, AAP guidelines do say we can remove the diaper if it is so high that it is going up to exchange levels. but I would say we'll be caution. Maybe just put a small area of the diaper just on the genitals, not to damage them. But the evidence are that you can.
So question number, another question for, if there is a 28 days newborn with a diagnosis of gallstone, how to manage it? And question number 2, what is the incidence of choledocholithiasis in neonatal period?
Is it for me? Sorry, you're talking about gallstone and choledocholithiasis.
Yes, sir. Yes, sir.
Yeah, see, gallstones, basically, we are coming across a lot of scans which we do for other purposes. People pick up this sort of stones, both in the gallbladder and in the biliary tree. So some of these stones are nothing but sludges. So this sludging could be because of 2 reasons. Any sick child could have biliary sludging because of lack of cholinergic effect and lack of enteral nutrition. Second reason is if there is excessive hemolysis, it could happen. So these are the 2 common reasons. Any sick child, lack of enteral feeding causing sludging, which could be reported as a stone in the CBD. And so what I would do is, I would reevaluate the babies otherwise well having normal colored stools, and the baby jaundice levels are not alarming. Then I would reevaluate this after a month's time once the baby starts picking up weight, when the feeding starts established. Most of these reports of there being choledocholithiasis goes away. But if it is still there, I think it's a big workup. If choledocholithiasis workup, it's going to be quite big. Hemolytic disorders are the ones we need to look at more commonly.
Thank you, Dr. Naresh. Now, Dr. Guru Prasad has raised the hands. Guru, sir.
Yeah, good evening, Prashant.
Good evening, sir.
Good evening, Dinakar. Excellent presentation, Dr. SIDDHARTH and GIRIDHAR.
Thank you, sir. Thank you very much.
Especially, you have the art of making complex topics very simple. Cholestasis can't be made more simpler than this. I think they
all your blessings, sir.
Yeah, I'm proud to see our students doing so well, and you are all excellent teachers.
Thank you, sir. Thank you very much.
I have something to SIDDHARTH. SIDDHARTH, unfortunately, we continue to see hyperbilirubinemia as an unconjugated hyperbilirubinemia as an ongoing threat. And if you look at the data of most of the referral centers, the exchange transfusions are done for something other than RH and EBO hemolytic disease. Very unfortunate that we get referrals with bilirubins of 30, 34 even today. No setting for blood group incompatibility. You can't blame the treating physician or the practitioner or anybody for that matter. So we should be very alert, especially when you are discharging an infant from the hospital at least. I know in corporate hospitals you may not see. Our own data last 10 years, we have seen more than hundreds RH hemolytic disease referred from across the central part of Karnataka. And regarding procedure that to be done for exchange, ideally it should be completed, if I'm correct, 45 minutes to 60 minutes at an average 1 alicard per minute at that rate. If you keep anything more than 1 hour, there will be always procedure related risk. So ideally you should finish the procedure by 45 minutes to 1 hour. I just have a question to Dr. Giridhar. Giridhar, just having covered, what is the current status of liver transplantation for our infants and young children with cholestatic problems? How many pediatric liver transplantations have been done, and what are the good centers that you can suggest?
So I'm not aware of exactly how many have been done so far across India. At least our center means the center was working earlier. Partly was associated with a hospital called Global Hospital in Chennai, where the very famous liver surgeon Dr. Mohammad Rila was there. Yeah. So I think we had actually in 2016 given a publication, and so about what are the 96 cases of pediatric liver transplantations which were done. So basically, this was the demography, which was etiology and the demographic characteristics of all the 96 patients. So I think their experience is about the auxiliary liver transplant, where the part of the liver is respiratory liver transplant is being done. So basically, because the surgeon's skill is also very important here. I think Dr. Mohammad Rila had done in a newborn. We have seen newborns as small as 28 days babies getting operated, but that is not for neonatal cholestasis. They got operated for liver failures. actually. So they had other etiologies for liver failures. So I think here, I think the center is offering, good response rate in the short term, not the long term, because still we don't have long-term data about short-term response rates in terms of resolution of all your cholestasis-related symptoms and growth revival. It's about 85 to 90%. So I think that's a very good rate. So, but I'm not aware of the results from other centers. I know there are a lot of centers in thing. I've personally talked to Dr. Neelam Mohan, pediatric gastroenterologist at Max Hospitals. I think their numbers are basically the same as what it is in Chennai. I think it is. Since you are an expert on jaundice, sir, you can share your experience also, sir.
No, I know Muhammad Rila has done wonderful work. I met him in one of the meetings in Bangalore, and
Yes,
he is an international repute liver transplant surgeon. As you rightly said, he has operated in a 1 month infant also.
Yes, sir.
At least liver transplantation is happening in our country. That is something that we can really think about. Those are affordable and treatable conditions.
I think the problem which we are seeing is actually the availability of the graft is becoming difficult, because now all your organ transplantation are streamlined by the particular committee, and it has to come through the committee. Now, if you want to fast track the procedure, it is not possible in the legal way. So I think some of the kids who actually require it, they should still await a fast track process which comes through legally and get it done. So at least there are options. Good centers are doing it, and I would say that it's quite expensive. I think you can talk with the parents, give them the option that these are available, and let them take a call on them. Sir.
Thank you. Nice talking to you.
Thank you, sir. Thank you, sir. Stay safe, sir. Nice talking to you.
Yeah, fine. Nice to hear you.
Thank you, sir.
Fine.
Hello.
We have Dr. Kotreshi, sir, for NNF chapter president. Over to you, sir.
Morning, sir.
Good evening, sir. I'm very thankful you for Dr. Giridhar and Dr. SIDDHARTH giving a wonderful presentation on hyperbilirubinemia and both the things. And it's an excellent presentation. I got a question anybody can answer. You must be using the different modes of phototherapy units. Earlier it was a blue light, now the LED phototherapy. What is the proper guidance? What is the strict guidance on using the phototherapy unit for the baby, including preterms?
So, like what kind of light, sir?
No. I would like to know the type of instrumentation, the measurement and distance both, and what is the type of duration, and how we interpret phototherapy, including preterm and regular term babies.
So LED lamps are the best to use right now because they are most effective and they are in the target range of bilirubin. For depending on your nomogram chart, we have to decide on whether there is a need for phototherapy or not. If you want to give intensive, you can go as low as 10 centimeters near the baby, but somebody needs to keep temperature checking properly. For preterm babies, biliblanket is a kind of safe, skin-friendly alternative, and it has a decreased amount of radiance. So if there are only low levels, you can do just a single biliblanket for them, unless the level is high. So if you need to increase your intensity of phototherapy, it needs to go up, like the bilirubin is not coming down under light, your rate of rise is rapid, or you're nearing exchange level, then you need to do intensive photo.
Okay. Thank you. Dr. Paramjit is online. Dr. Paramjit?
Yes. Am I audible?
Yes. Please go ahead.
I'm a senior consultant pediatric unit in New Delhi Rainbow Children's Hospital. I'm a general pediatrician, but also look into the neonatal ICU as a part of the team. One good thing which I learned from Dr. SIDDHARTH and Dr. GIRIDHAR was an excellent talk, enlightening talk. So my question to Dr. SIDDHARTH, I have a patient, it will be just a general question for a general pediatrician. So just be general about that issue without the nomograms. I have a 5-day-old child born to a normal, healthy mother who has gone through a proper checkup during the antenatal period. There is no incompatibility of blood group incompatibility. The child has been discharged on the day after 3 days of a normal vaginal delivery, comes to on the 5th day to me with a bilirubin levels done by somebody told them just get the blood because their family physician is also attached on the 5th. After completing the 5th day, on the 6th day comes with 18.9 total bilirubin, practically done by a good method, by a good lab, and practically predominantly indirect bilirubin. Would you like to give phototherapy? The answer is there is no nomogram I have. Would you like to give phototherapy between 18 to 19, or would you like to wait with the child practically happy, healthy, feeding well, and the report has been doubly showed practically. So answer should be very clear for a general pediatrician without the nomogram.
Sir, one thing for a baby who on day 6 who has no other risk factors and is thriving well, and the feeding is going well, it is below your cutoff level for photo. So 20 would be your cutoff level if he is a term baby, like more than 38 weeks. But ideally, we should always have a nomogram pasted in the OPD because that is what is recommended. And though this is the knowledge from the nomogram, that it is 20.
So we can, my question. Okay, you continue first.
Yeah, so we can wait with phototherapy just to make sure that the baby comes back to you for review in 2 to 3 days, and you know that the jaundice is not increasing.
So your take-home message is that can we wait in such children till 19 if there are no risk factors, and maybe after 24 hours repeat a bilirubin, and if it is not rising and then falling on the 7th day or the 6th day, then is it practical, or should we just put them inside after 18 or 19 and irrespective of the nomogram?
I think that decision has to be done with the patient if they're willing to come back for follow-up.
They're a good patient and they've taken 2 opinions. One doctor is saying you wait, 18.5 is nothing. One is urgently wanting the child to get admitted. So I generally do a practical approach in 18.5 in such a child that wait, okay, let us repeat the test within next 24 hours. If it is rising, I will admit. If it is not rising, I will not admit. So which one is the correct doctor at present, or which is the one which you would follow?
I think it's valid to wait for a day. If they're willing to come back, we'll do a testing again just to make sure the bilirubin is not going up, because 18 is not level for 6th day jaundice.
Right. So on this, so accordingly, we should follow ideally the nomograms. But in case of a person, I just want to tell you that only that a person who is in a remote area, a general pediatrician with family like a DCH sitting in a remote area who doesn't have access to a nomogram, my message is basically we can wait between 18 to 20 in such children, give them time, maybe after 12 or 24 hours, maybe sometimes I advise in my children, though it may not be recommended, sunny days for those children, and practically with my own experience, I've got good results.
Dr. Paramjit and Dr. Kishore here. If you don't have access to the nomograms, you can download in the mobile an app called Billy app, which calculates what is the range of phototherapy, and it has got all the nomograms, and you can actually plot it and see whether the baby is safe to be discharged or not. So you don't have to worry about carrying the nomograms.
Okay, no, that was we do have the nomograms. I was just talking about in the places who don't have. So which is the app?
Every doctor will have a mobile phone, so you can download the app called Billy app.
Okay.
And they can carry that with them.
Thank you.
I'm sure no doctor will have no mobile phone.
Okay, so that is a good thing which one would have in addition. Thank you so much.
Thank you, sir. Kishore sir.
Siddharth and Giridhar, wonderful sessions.
Thank you.
I
Sir.
just wanted to mention one point. We were talking about liver transplant. We had sent 2 of our babies for a liver transplant to Delhi, and
Yes,
it's a package. It cost 28 lakhs.
Yeah, 25 here.
And in Bangalore, with the crowdfunding, they do nowadays for a liver transplant at 3 lakhs. So just for the information of various people, there is crowdfunding available. Liver transplant is being done in Bangalore, and it is about 3 to 5 lakhs maximum. And definitely we've had quite a few babies with the metabolic disorders, sideratinemia, doing very well post liver transplantation in Cloud9. Thank you very much.
Thank you, sir. Thank you.
Yeah, Dr. Ashwij.
Yeah, we have few last minute questions. Can we take?
Yeah, please.
Yeah. Okay. Now, does early aggressive TPN increase the risk for PNLD significantly?
No, I think PNALD is a multifactorial thing. So it is actually prematurity per se could result. Your lipids, some of these peroxidation products of lipids could cause PNLD, sepsis, lack of enteral feeding. So all this could be contributing. So aggressive nutrition, just we use it, doesn't say that it results in PNLD, but that is the reason we keep watching out for, when we keep monitoring the LFT levels in this baby. See, after we start this babies on aggressive nutrition, around 24 to 48 hours later, we'll take a LFT. If it turns out to be normal, we repeat these liver function tests every week. Baby is remaining on TPN. So I think aggressive nutrition does not increase PNALD. Now, since your SMOF lipids are freely available, I think you could also consider changing your intralipids with SMOF lipids, because SMOF has been found to be useful in treatment of PNALD, but still as a preventive agent, it has not been found to, it has not been tried out so far. But whatever studies we have says that the PNALD is less with SMOF and compared to your intralipids. That is a soybean-based lipids. So aggressive nutrition, no, but keep monitoring.
Last couple of questions to Siddharth.
Can I just add on to that? I think the early aggressive doesn't cause cholestasis, but the duration of TPN has been related to cholestasis. The number, not the start of it.
Okay. How many exchange transfusion at maximum can be done? This is to Siddharth.
There might be repeated exchanges needed, like second, third. I'm not sure if there's any maximum number to it. I don't know.
Yeah, sure. Dinakar sir?
Yeah, very nice. I think so. Both people are from Tamil Nadu. There are so much corona is there in Chennai, and I don't know in Coimbatore. So I think so. Everybody, 287 members who have 297 members who logged in. I think so. Giri, everybody should go to quarantine.
So
yes,
this is e-spreading of corona. So I think we'll have one report saying that how people who are logged in a Zoom call were all affected. Yeah. Now the entire Bangalore crowd is going to come down with corona, and again they're going to start blaming Chennai as being the problem.
No, Chennai once leave it, Giri. They will tell it is a Zoom. It is from China, so China has spread.
Nowadays, whomever we test in Chennai is turning out to be positive. So I think we don't know. I think this would be a good research potential also. After a Zoom call, people turning out to be positive. As it related to the Zoom, we don't know. Again, China could be giving something there.
Siddharth, very nice topic. Really happy to talk and listen to you, both speakers. So good. Over to Prashant.
Thank you, sir. Thank you very much. Well, lovely talking to you.
The longest discussion session. Thank you very much for such comprehensive and wonderful discussion, having patience exhibited during discussion. Thank you very much. I would like to thank all the participants. As I said, this day after tomorrow, we are having one more webinar session on neonatal skin and orthopedic. This is for the first time we are doing it here. So we will have a lot of issues in our practice, in our OPD practice. We would see some rashes. We get confused with normal variants. So come do join us, and we will try to have a collective discussion and try to solve the practical problems which are not there in the books. So neonatal skin, when it comes, there are certain things which we need to know, and all the things may not be written in the book, but it comes out of experience. Come do join us. We'll see you day after tomorrow, Saturday at 5 p.m. same time. Thank you very much. Thank you very much for joining us. Bye.